And so if we think about the beginning of a patient's course with primary breast cancer, up front they undergo surgery and other treatments, whether that's chemotherapy, radiation, and then certainly surgery being a mainstay of therapy. And usually the ctDNA content should drop to 0. ctDNA has a half-life less than 2 hours. You should not have residual ctDNA if there's no residual tumor within the circulation. And as we know that in order to reduce recurrence risks, we'll give adjuvant therapy to minimize that risk. And ostensibly, if there's no tumor content, there should not be circulating tumor DNA, and so it should stay at 0. Now, unfortunately, almost a third of patients do experience relapse, and so thinking about the ctDNA content, often it does start increasing prior to clinical recurrence. And so once clinical recurrence has occurred, because the tumor content is larger, we would anticipate the ctDNA content to be larger and larger than it was in the primary most often. And then we treat. And when you treat, we have data to suggest that ctDNA often decreases in response to treatment, and it should return, often it won't go back to 0, but it does get low. And then unfortunately, the other thing we know is that cancers develop resistance. And so at that point, one early evidence of an evolving resistance and progression is a new increase in ctDNA. And then clinical progression succeeds that. It tends to happen after the initial ctDNA increase. And then again, the cycle continues of continuing treatment.